Okay, so this is where we stopped in class. I'm hopeful that most of you were able to complete this because there's some of this is going to show up on your post-class engagement as well. Um, I'm going to record the rest of this lecture online because unfortunately I have a funeral to go to on Wednesday. So um, we won't be having in-person class. Um, okay, but I just really quickly wanted to briefly go over this. So to calculate total cholesterol, you should be adding HDL plus LDL plus 20% of the triglyceride amount. So you should have gotten 208 milligrams per deciliter. The ratio of triglyceride to HDL is just triglycerides divided by HDL. So 180 divided by 42. So you should have gotten 4.29 there, which does indicate increased risk for cardiovascular disease. Based on the profile, two lifestyle changes. So I would say decreased fat intake. We could go with reducing weight uh, or increasing exercise. If increasing exercise is the direction that Richard decides to go, then I would say combined training is probably the best recommendation for him with a high frequency. So looking at maybe like 5, 6 days a week, maybe switching on and off with aerobic and then resistance training. Okay, so we are going to briefly cover overweight and obesity here just because it's covered in chapter 9 as well. But we did quite a deep dive on overweight and obesity earlier, so I'm not going to spend too much time here. But you should be familiar with the fact that 70% of the US population is considered overweight or obese, whereas 40% of it is considered obese. And again, that distribution is not evenly across the United States, so we do see greater amounts of obesity in these sort of Midwestern and Southern states, as opposed to, for example, the coasts of the country. The cost here is about 190 billion a year estimated. So again, these are related to direct and indirect costs. So note that that's sometimes just loss of productivity. It's sometimes loss of individuals due to mortality, right? So then they're no longer contributing to the economy. And the reason I bring this up is just because it's frequently used as a way to solicit funding for a given research area or given medications, right? It's actually costing the country money every year to treat these chronic diseases. Um, However, I will say there are no contraindications to exercise as a result of having been diagnosed with overweight or obesity. So anyone who has been diagnosed with this can still exercise. Having said that, sometimes we refer to multimorbidity or multiple morbidities. So oftentimes overweight or obesity is just one of the things that an individual has been diagnosed with. So they may have also been diagnosed with metabolic syndrome, for example, or hypertension or diabetes. And in that case, there would be some contraindications. But if it's just for overweight or obesity, we have no contraindications to exercise. You should be familiar with the BMI classification scale. And also, you should be familiar with, at the very least, these two cutoffs. So we've got 40 inches for males, or 102 centimeters, and 35 inches for females, or 88 centimeters. And you should be familiar with those because we do see significantly increased risk split down the middle of those risk factors. So I want you to know at least those. Ideally, I would love for you to be familiar with this because I think that waist circumference is really a better measure for health risk than BMI is, particularly on an individual level. And I think actually waist to hip ratio is an even better measure. But in any case, I do expect you to be familiar with this recommendation. So how then would I change the fit VP principle? So we're really looking in this population for 1 to 5% body weight loss, or sorry, 1 to 5% is what you could expect with exercise. Ideally, right, for clinical weight loss, clinically significant weight loss, we'd expect to see at least 3%. And at 3%, we can sometimes see clinical changes. But with 1 to 2%, which is pretty common with exercise, I wouldn't expect to see any clinical changes. So some ways to get at weight loss through exercise, right, is through increasing frequency, right? If I increase the frequency, then that's going to increase theoretically the total number of calories expended in exercise. If I increase my timing to greater than 150 minutes every week, again, you saw a couple weeks ago where we saw sort of a dose response relationship with the number of minutes spent in exercise and the amount of weight lost, where I think we stopped at 420 minutes per week, and greater than that resulted in about 8 kgs of weight lost. Whereas in the greater than 150 minutes, I think you were looking at 2 to 3 kgs. Okay. Additionally, HIIT is often recommended for this population. There is some interesting research that shows increased enjoyment with high intensity interval training. Just for the record, and we covered this back in, I think, week 3 and week 5, but interval training, high intensity interval training is referring to aerobic specific training. Now, there are hybrid training modes that are often called high intensity interval training. In most research papers, when we're referring to HIIT, it's aerobic specific training. So I'm looking at potentially swimming, but mostly I'm looking at cycling and running and walking, maybe rowing, an elliptical, right? Typical full body aerobic movements. But yes, with HIIT specifically, so these high intensity intervals followed by lower intensity intervals, we do see typically increased enjoyment and increased weight loss in when we compare it to just moderate continuous training. The goal, right, is to lose 3 to 10% of your body mass over 6 months, right? That's that 3% of clinically significant weight loss. And combined interventions are typically more effective than isolated interventions. So that's when we look at combining aerobic and resistance training in the same week or even in the same session, as opposed to just doing aerobic training across the week or just resistance training across the week. And we saw some of that when we were looking back at even like dyslipidemia, right? So we saw combined training was most effective for LDLs. It was also most effective for triglycerides. It wasn't more effective for HDL, although the magnitude of change here wasn't super high anyway. And combined training was also the most effective for changes in total cholesterol. So in any case, combined training really does seem to be our most effective type of training if we're trying to combat some of these diseases. Okay, so you've already seen this, so I'm not going to go over it too much. I just wanted to cover different weight loss interventions. So I wanted to remind you that the ways that people lose weight are one, yes, through exercise. That's actually not on here anywhere because we typically don't see clinically significant weight loss with an exercise-only intervention. So the calorie study was just based on reducing total number of calories. Diet Fits was a change in macronutrients that resulted in a caloric deficit. Tirzepatide is a GLP-1 and GIP agonist drug. Semaglutide is a GLP-1 agonist drug. And then RYGB is bariatric surgery. Okay, so those are the ways that people are effectively losing weight. And typically when we combine multiple ways, we actually see greater weight loss. And you're going to see that in the next slide when we're looking at lifestyle-specific interventions. Okay, and I think I cover that here. Do I cover that here? Oh, I do. Okay, great. So I do want to talk about weight regain as a result of specifically lifestyle interventions, right? So pharmacologic drugs, so medication isn't considered lifestyle intervention, nor is bariatric surgery. These two would be considered lifestyle interventions, right? Because they require a change in diet. So we're specifically focused on diet here. And some people, I tried to find this number, but some people will say that you gain back, if you lose weight entirely through diet, that you gain back like 95% of that weight in a year. Now, what I think people are referring to is that you still you typically retain at least a 5% body mass weight loss. So maybe that's where that number is coming from. I'm not sure. But at least in the research that I've looked at, you're looking at about 50% weight regain after 3 years. So let's say you lost, in this particular study, you lost about 10% of your body mass. So this was post-intervention. So at the end of an intervention, these individuals had lost about 10% of their body mass, okay? And then we followed them up to 160 weeks, right? So across about a 5-year period, and we did see weight gain, but you can see it looks like it's starting to level off here at about that 5% weight loss range, right? And that is still clinically significant. So even though you are likely to regain some of the weight that you lost as a result of a diet intervention, it's still worth it to do the dietary intervention if I can maintain that 5% weight loss. In order to have an effective dietary intervention, we do see that increased duration of the intervention is helpful, as well as continued support after the intervention ends. So continued support could just be someone calling in to check in and see, okay, how is your weight loss journey going now that you don't have all the support that we had in the program, right? The duration of the intervention could be as short as like 2 weeks, for example. I could have an intervention where I have people come in and I really educate them on dietary strategies to reduce weight. But what they found is that interventions that lasted a longer period of time also resulted in less weight regain post-intervention. So if I have a 16-week intervention, for example, so for 4 months, maybe I did some diet, maybe some exercise or intervention, right? I got them a lot of support. I helped them maybe establish healthy patterns that was more effective long term. Okay, so that's what you see here in terms of dietary interventions. I do want to point this out too, and there's a link to this in the slide notes if you download the slides. But it's really messy to sort of look at. But they looked at the combination of different lifestyle interventions. So they looked at diet plus behavioral counseling, diet plus exercise, behavioral counseling plus exercise, diet and behavioral counseling and exercise. And interestingly, typically we would think that, okay, the more aspects of the intervention that you have, the more effective it was. But that's actually not what they found in this study. So they found that this diet and behavioral intervention was not more effective than the diet and exercise intervention. And actually, that even the behavioral plus the exercise intervention was more effective. So multiple interventions was more effective than a single intervention, but 3 or more interventions was not necessarily more effective. So the most effective strategy in this group was when you combined diet and exercise. So even though I do sort of harp on the idea that diet is really how people lose weight, in this case, they're really looking at weight regain over a period of time. So this was over 160 weeks, so again, about 5 years. And that weight regain especially is significantly blunted if you include exercise as part of the intervention. Okay, so, but then I want to compare lifestyle interventions to the pharmacology and bariatric stuff as well. So for pharmacology, we see about 67% weight regain after a year. So that's compared to the 50% seen in the dietary group. And it does look like this is leveling off. So I wasn't able to find any data that showed a longer term intervention here where I saw a 3-year period, for example. But it looks like people are leveling off at about 67% weight regain. So even when they're coming off of these GLP-1 drugs, they're actually not putting on all of the weight that they lost while on these drugs. They are regaining, right, significant amounts of weight, but they're still maintaining greater than 5% weight loss. So again, that GLP-1 drug was still effective for them long term. And then you compare that to bariatric surgery, where we have 16 to 37% weight regain after 5 years. And these are all, if you're really interested in this stuff, again, there's some citations in the slide notes that you can go and sort of read about. But in any case, we see slightly less weight regain with bariatric surgery, and this is at a 5-year time point. So even for a longer period of time, but we still would expect weight regain. So it's helpful to give people expectations like, hey, yeah, you're going to hit some point at which you're probably not going to continue losing weight. And in fact, you will probably start to regain a little bit of weight. That's totally normal. We would expect you to level off with bariatric surgery at about, 70%-ish of your original body weight loss, right? And there is some really interesting research looking at GLP-1s as helping prevent weight regain after bariatric surgery. So in any case, right, again, combining multiple different interventions, you could also combine a bariatric intervention and a pharmacologic intervention and still have more effective results long term. So really that combination of multiple different modes seems to be super effective here. Okay, moving on to hypertension, you should all be familiar with this. This comes from chapter 2 in your text. And you should also be familiar with the idea that there's different criteria for hypertension. So we have the ACC and AHA, and then that's juxtaposed against the JNC criteria. So JNC criteria is slightly less conservative. They don't consider you hypertensive until you hit 140 to 159 millimeters of mercury for blood pressure, whereas the ACC and the AHA consider you stage 1 hypertensive at 130 to 139 in systolic or 80 to 89 in diastolic. So you should know that there is a difference in how we diagnose hypertension and what that is. So for an individual who has been diagnosed with hypertension, And also, just for the record, to be diagnosed with hypertension, you typically should have been seated for at least 5 minutes prior to taking blood pressure, and you should have at least two confirmatory measurements. So it should never be based off of a single measurement. And so when you go in, notice this the next time you go in, maybe for a yearly checkup or something. Typically, you'll come into a room, get seated, and immediately have blood pressure taken, right? Your blood pressure, one, is probably a little bit higher because of the environment that you're in, as well as the fact that you actually weren't seated for 5 minutes. So that's not your resting blood pressure, right? Because you did get up, you had to walk to the room, right? That does increase your blood pressure acutely. Okay. So if your blood pressure reading is high, sometimes what an MA will do is they'll leave the room for a couple of minutes and they'll actually leave a cuff on your arm and say, hey, this cuff is going to inflate at some point for a couple of times, and then they'll come back in and look at it at that point. So they are trying to give you that 5 minutes to rest before they potentially consider putting you on blood pressure medication, for example. The other thing that will sometimes happen is that a physician will send you home with a blood pressure cuff and say, hey, when you wake up in the morning, I want you to go ahead and measure your blood pressure because we think that when you first wake up, you typically have the lowest blood pressure that you're going to have. Okay. So this should be confirmed, but in any case, hypertension is one of the diagnoses that does come with a contraindication. So if you have a resting blood pressure of greater than 140 over 90, we would say don't engage in exercise at that time unless you have gotten clearance from a physician, right? You should be being treated for hypertension at this point. And then I do want you to pay attention to, okay, well, how many people are being treated with hypertension? So typically we have a prevalence of about 50% across men and women. And you see across men and women actually pretty similar results here, slightly higher levels in men, but pretty similar. And then notice across age ranges, so we've got 18 and older, 18 to 39, 40 to 59, and then 60 and older. So as we age, we do see an increased prevalence of high blood pressure, which makes sense, especially if we come back to dyslipidemia, right? We see that plaque build up over time, that those levels of lipids and glucose in the blood, right? Those can contribute to plaques building up, which then can contribute to hypertension, so we would expect to see that as somebody ages, their risk for hypertension goes up. You do see about an 80 to 90% lifetime prevalence, which is an interesting statistic to think about. So that's just what are the chances that you're going to be diagnosed with hypertension at some point during your life? The chances are very good. So if I were in class, I would be looking around and I'd say 90% of us are likely to be diagnosed with this at some point. So if you look to the people on your left and your right, they're all getting diagnosed and you probably are too. And again, this isn't uniform across the US, but the percentages are extremely, extremely high here. So what can I expect with then exercise? I could expect a 5 to 7 millimeter of mercury decrease in my blood pressure with regular exercise. And that's predominantly looking at aerobic exercise, but we do see decreases with resistance exercise as well. Now, if you compare that to a pharmacologic interventions, you're looking at like 8 to 15 millimeters of mercury decrease. So slightly greater with pharmacologic interventions as compared to an exercise intervention. You see the changes in the FitVP recommendations here. So greater than 5 days a week. So again, this is really common. What we're seeing in terms of combating chronic disease risk is that increased frequency, partly because it is associated with greater weight reduction, right? That increased frequency, increased time is associated with greater weight loss, okay, or creating these negative energy balances. The other thing to really pay attention to with hypertension specifically is intensity, right? So moderate physical activity is recommended. It's recommended to avoid the Valsalva maneuver. So in class, we talked about that bearing down, right? You should be avoiding that. If you're going to give some type of specific intensity prescription, likely you should be using RPE, especially because if someone's been diagnosed with hypertension, they are probably on some type of hypertensive medication. And hypertensive medications often will affect the heart rate and the blood pressure response to exercise. So those aren't going to be good measures of intensity. So RPE really is a good measure for this population. During exercise, especially in a clinical setting, I would want to maintain blood pressure below 220 over 105, right? So that would be an absolute contraindication to stop exercise. So if at some point I was doing some type of, let's say, HIIT training in this population, which wouldn't typically be recommended, right? Because we're recommending that moderate physical activity. But if I were doing some type of vigorous training and I got blood pressure as high as 220, I should stop exercise until I can normalize blood pressure again. And then the last thing here is an extended cool down. So especially with hypertensive medications, we can sometimes see rapid hypotension post-exercise. So this rapid drop in blood pressure after you stop exercising. And there's lots of reasons for that that you hopefully will get into more in exercise physiology. But basically, we have decreased venous return to the heart if we stop exercise immediately, especially if we were doing more vigorous exercise. So we could see someone passing out here, for example. And obviously, we want to avoid that. You can avoid that partially by extending your cool down. Okay, the last disease that we're going to talk about is not an individual disease, but it's called metabolic syndrome. And metabolic syndrome is diagnosed when you have three or more risk factors for other diseases, essentially. So if you come down to this table, this is in chapter 9 of your book, which you should be reading this week. So first you have waist circumference. Okay, so I like WHO's definition. So these are different organizations. And that's one of the issues with metabolic syndrome is that we have different organizations who categorize things differently. I prefer WHO's definition here because they use the waist to hip ratio, but you could use the IDF or NCEP as well. And you note that that's that recommendation that I expect you to know for waist circumference, so that 40 inches and 35 inches in females. We also have blood glucose regulation, which we talked about earlier, right? And you should be familiar with the idea that greater than 100 milligrams per deciliter using fasting blood sugar testing is a risk factor, right? And that's sort of used across the board here. We've got dyslipidemia, right? And you should also be familiar with HDL risk levels and triglyceride risk levels. We've got elevated blood pressure, and here again, used in these two, we're using a stage 1 hypertension level, whereas here we're looking at more stage 2 as defined by the American Heart Association. Okay, so slight differences, but not massive. So, but those are our categories. So we've got weight or waist circumference. We've got blood glucose, dyslipidemia, and we'll go 2 categories of dyslipidemia because we're looking at HDL and triglycerides, and then blood pressure. So you've got 5 different potential diagnostic criteria, and you need to meet at least 3 of those to be diagnosed with metabolic syndrome. Okay. According to NHANES, the prevalence of metabolic syndrome across the US population is about 34%. The only contraindication to exercise would be specific to hypertension, right? Greater than 140/90. I will say, though, if you go back to the diabetes section, right, if you had a blood sugar level below 90, for example, that would also be a contraindication here. So the only difference for prescription is the change in time here. So significantly higher time, 250 to 300 minutes is what's recommended. And again, really looking at that weight reduction piece because that would influence all of these other factors. So you should be familiar with the idea that metabolic syndrome requires 3 risk factors to be met. You should be familiar with the 5 risk factors that we just went over, as well as diagnostic criteria for each, which you should, for the record, already be familiar with because it takes you right back to chapter 2 and those risk factors for cardiovascular disease. Okay. Okay, those are all the diseases we're covering, but I do want to comment on the metabolically healthy obese population because it's a population that's been studied more lately. So a lot of you might think that sounds like an oxymoron. You can't be metabolically healthy and obese. You actually can. Okay, so that would indicate somebody who only meets, for example, this waist circumference criteria. Okay, but they actually have normal levels of blood glucose, normal lipid levels, normal blood pressure, right? They would be considered metabolically healthy, right? So no dyslipidemia, no hypertension, no diabetes, but still obese, okay? And there's this idea that, so with the movement, healthy at every size, for example, there is this idea that, okay, well, if you're metabolically healthy and obese, then that's okay. Being obese is fine. The research does not support that. Now, I 100% support the idea that you can be metabolically healthy and that is a great thing for you if you are obese. It does not mitigate your risk for specific diseases, though, or at least not entirely, right? So if you are metabolically healthy but obese, your risk for coronary heart disease is still increased 49% compared to someone who is considered normal weight and not having these metabolic risk factors. Okay. You also have an increased risk for cerebrovascular disease or stroke. Now, 7% increased risk, I'm actually not super concerned about stroke in this population, but I am concerned about heart failure and coronary heart disease. So it seems like that obesity is really affecting heart much more than it is brain or blood vessels. So things like peripheral artery disease, I'm not going to be as concerned about, but like, could I see some serious heart issues for this population? 100%. Okay. And this is data that was based on a massive study out of the UK. They sampled 6% of the population, which I know that sounds like a small portion. To analyze 6% of the population is wild. It takes so much work. So the other thing that I have in the slide notes here is that your risk for type 2 diabetes in a metabolically unhealthy population compared to a metabolically healthy population it's 8.93 in a metabolically unhealthy population. So your risk for diabetes is almost 9 times higher than it would be in a normal weight, normal metabolic functioning population. In the metabolically healthy obese population, your risk for diabetes is 4.03, or your relative risk is, meaning you're 4 times more likely to you're 4 times as likely, you're 3 times more likely to develop type 2 diabetes. So your risk for diabetes as well as your risk for heart complications do still go up in this population. Okay, last slide here. I just want you, so this is looking at all-cause mortality. So it's not any of the individual diseases we looked at, it's just mortality as a whole. And I just want you to sort of puzzle out the difference between sedentary behavior and physical activity. So we know that they have independent effects on health, but here we're looking at hazard ratios. So that's my risk for death, right? And my risk for death at 1 indicates that's everyone has a certain level of risk for death, right? And in this paper, they used people who were getting less than 4 hours of sedentary behavior every day and greater than or equal to 420 minutes a week of physical activity. And that was your reference group. So compared to that group, right, how much risk do I have for mortality? And they looked at different sedentary categories, so less than 4, 4 to 6, 6 to 8, and greater than 8. And they also looked at different physical activity categories, right? Greater than 420, 300 to 420, 150 to 300, 100 to 150, and then no physical activity. So I do want you to take a minute, go through this, figure out what patterns are. And I'm going to run you through just a couple. So the first one that I'm going to say is not a single data point here crosses this line, which that means that everyone in this category, so everyone not getting any intentional physical activity, had significantly increased mortality risk. Okay. In this population, we also saw this one doesn't actually quite cross 0. So everyone in this population getting 100 to 150 minutes a week also had increased mortality risk. However, when we get over to here, so people meeting physical activity guidelines, right, 150 to 300 minutes a week, your level of sedentary behavior didn't increase your risk for physical activity until we got to greater than 8 hours per day. So you had to be seated for more than 8 hours per day to have increased mortality risk if you are meeting physical activity guidelines. Now, for the record, most people are actually sitting for more than 8 hours a day. That's pretty common in our society when we look at accelerometer data. But in any case, that's something that's I could communicate with a client and say, hey, if you can meet these guidelines, right, your increased risk of mortality is not likely to be very great if there is any at all, and you'd have to be getting more than 8 hours of sedentary behavior a week. In these two highly active categories, right, we saw no increased risk for mortality, even with people sitting more than 8 hours per day. Okay, slight trend toward it here, but that still crosses my baseline level of risk. Okay, so in any case, interesting to look at the sedentary behavior piece and how that interacts with the physical activity piece as well here. So you've got a post-class engagement. There's no time limit on that. I hope it's pretty self-explanatory, but do expect something like the case study that you're going to see in that post-class engagement. Expect things like that on your exam. Expect things like in class, right? I gave you that resistance training prescription, and then I said, okay, how would this change for a diabetic person? Expect questions like that on your exam. If I tell you somebody has hypertension, how would you change their recommendation? I do expect you to be able to tell me I would increase their frequency and I might extend their cool down, right? I do expect that level of knowledge and application of what we've learned to a specific individual. Okay. Okay. Good luck and please reach out with questions.